You read a question, you don't have to answer questions, how to approach NCLEX question just from the back. This will give you focus. Select or apply. That means I can pick anything I want from here. But for the new NCLEX, what you need to do, 101%, 110%. That means you have to be 100% sure the answer choice you picking, but you have to go up 10%. Which of the following medication, right? Underlying medication. The next no is indicated. That means one of those is indicated. Do I have to pick all of them? I don't know. And next is performing medication reconciliation for a client diagnosed with fibromyalgia. That's your keyword. So I have a patient who has fibromyalgia. And then I want to know if any of this medication is indicated. Fibromyalgia, there's three things that worry about it. They have sleep issue, okay? They have fatigue, and they can have depression. All from what? Pain. So you can see that these people, you can't just manage their pain. You got to attack every aspect of their problem. They have trigger points everywhere. They get tired easily. You have problem. So what do you think? What do you think? I've given you the content. You see, I go right to the jugular. They have a sleep issue, fatigue, and depression, all coming from the pain. You see anything here that can take care of depression. If you take it, if you see it, you pick it. Do you see anything that can help with the fatigue? You got to pick it. Do you see anything that can help them sleep? You pick it. Do you think there's anything there that can help with pain? Why don't you pick it? You see, straightforward, right? Naproxen. It will help with the pain, right? NC. You said what? Pregabalin. Yeah, that is an anti-epileptic. Yes, these people, they need something we call multimodal pain therapy. Therefore, one of the classes of medication we use for multimodal pain therapy is anti-epileptic. Think about trigeminal neuralgia. You know the medication is used for, so this is right. This is Flexeril. It's going to help their muscle. Okay, cyclobenzaprine. Easy, right? And then you have these two guys. Can you recognize them? If you do, then you can figure out that you know that Dilucitin, this is a SNRI. It's useful. It's an antidepressant. You can use it here. It can also help with the pain. And a TCA, amitriptyline, also help with the pain. It's also an antidepressant. Therefore, 1, 2, 3, 4, 5 are correct. You just on this content and this idea of what you need to target to take care of this patient. Making question answering not that difficult. You have to break it down, spend time, but you have to study your content. Like I said, if you want, you should check out that class. This one, you've seen it before, right? It's a long sentence, but there's only one word you need to focus on. It's a select or apply, the same thing. You don't have to pick all of them. Which of the following statements at discharge, that means statement, says something, patient said something, indicate what? Correct and underline, correct understanding of the diagnosis. What is the issue? Client is being discharged after diagnosis of what? Diverticulosis. Diverticulosis is going on. And we want to know what he's saying is correct. You have your sigmoid here like that, sigmoid colon. You have out pockets, little bit pockets. This is diverticulosis. How did it happen? Straining. How did it happen? Lack of water. How does it happen? Lack of exercise. You see, that's what they use to write those questions. And look at the answer choice. The things I said, if it's there, you go in, you pick it. So, what do you think? I will drink 3 liters of water a day. Is it okay? I will increase my intake of low residue diet. I will use Docolas daily. I will avoid caffeine. I will exercise 3 times a week. What do you think? What do you think? Which one is correct? I can tell you not all of them are correct. Not all of them meet the criteria. So drinking 2 to 3 liters of water a day is good to prevent the constipation so that they don't strain. I will increase intake of low residue diet. No. High fiber diet. I will use Docolas to daily. This is what people confuse with it. You should not use anything to stimulate you. You want to go regular, natural way. That's why fiber is the natural way of going to the bathroom. If you use Docolas, you're stimulating yourself. Therefore, 3 is wrong. I will avoid caffeine. Yeah, caffeine can dehydrate you. It's also a stimulant. You lose a lot of water. You can't be drinking 2 to 3 liters of water a day and then drinking coffee. So if you avoid it, excellent right there. I will exercise 3 times a week. Excellent. 3 times a week, at least 30 minutes minimum. So 145. You see, just a concept. Okay. 3 questions. Number 3. A nurse is caring for a client receiving mechanical ventilation, right? It's being intubated. Client is intubated. High pressure alarm, highlighted, were registered multiple times. The nurse should anticipate which of the following as a potential cause. What is the buzzword? I call it the buzz. It's buzzing in your ear like a bee. See, that's the way. When you're taking your test, you ask yourself, what is the buzzword? I need the buzzword because if you focus on the buzzword, it will take you to places you love to go. That means right answers, right? It's the gateway to get into the right answer. High pressure alarm. That's all. What is the content over there? If this is the patient, and there's a tube connected to a ventilator, there should be easy flow of pressure going back and forth, back and forth. When you block it, pressure goes up, like your toilet. If there is no connection, pressure goes down. That's all. So every time you see, I hear people ask me, what is the difference between high pressure and no, look. The ventilator is providing oxygen, air, and using pressure to push air into you. If there's a blockage, the alarm goes up. If there's no blockage, there's not going to be alarm. You have low pressure alarm. So it's not going to be high. High pressure alarm means blockage. Low means there's no connection. There is no blockage. And that means you've lost connection. No connection at all. ET tube disconnection. Think about it. Mucus plug. What does it look like? Half leak. Remember, they take the content and then they change it. You have to interpretate the answer choice to the content that you know. What I'm saying, high pressure means blockage, low pressure, there's no true connection. I take each answer choice and interpretate it in the concept of that. Is he indicating a high pressure or low pressure? If it is, then it's your answer because they're not going to tell you that. So ET2 disconnection, that means I'm disconnected. There's not going to be pressure anywhere. But it can't be right answer, right? Mucus plug. Hey, yeah, there's a blockage there in the patient. Yeah, it's going to increase the pressure. Calf leak. There's a break here, so air will leak out, and there is not going to be high pressure, right? Self-extubation. Patient pull the tube out, so there's no more tube. There's no connection between the patient. It will be low pressure. Then pneumothorax. Pneumothorax, you have air inside the outside of the lung. It's going to push on the lung, and that will create pressure filling in your lung. And the ventilator will have difficulty putting air in your lung. That's what they mean. Pneumothorax is going to create high pressure alarm. If you think about it, this is your trachea, this is your lung, and then the ventilator is coming here like that. This is the ventilator. It's trying to put air here, but you have pneumothorax pressure here from the air outside pushing on this lung, compressing it. There will be a lot of force to open that lung. So this will create high pressure alarm, mucus plug, high pressure alarm. So number 2 and number 5. Like I said, it's a select or apply. You don't have to pick everything. If you know only one, pick it. But I know you know more than one. You know, based on your concept, ET tube disconnection, calf leak, extubation, he's saying the same thing. There's no connection. The mucus plug and pneumothorax, there is a bunch of pressure going there. So 4 is a wrong answer. 4 is not right. Okay, guys. Adapt and proceed. Welcome. This is the ABG. Do you know how to solve ABG? And I want you to check Adapt in class. pH of 7.2, PCO2 of 40, bicarb of 18, PO2 of 90, SAT of 98. What will be the acid-base information here? What do you think is that? Is it respiratory acidosis, metabolic acidosis, metabolic alkalosis, respiratory alkalosis? What do you guys think? Which of the following order the name should anticipate from the carinase? What kind of ABG? If you get this ABG, what will you write down? If I ask you what is the ABG for that? Like I said, if you need ABG free of charge, you should check out that thing class. So which one do you think? What do you think this is? Is it whatever it is? Look at it carefully. Whatever strategy you have, that's fine with me. So far as you're able to identify what kind of acid-base imbalance do we have, then you go, right? If you're able to do that, halfway, you solve the question. This pH is low, so it has to be acidosis. This bicarb, it's way down. Like CO2 is normal, therefore this is metabolic acidosis. You know the way I do this acid base, you have to also know what is the compensation. This is the way to answer this question. Which of the following order the nurse should anticipate from caring physician? When they give you ABG, it's not enough, doctor. You have to know what to do with it. The patient has a metabolic acidosis. And so what? There's some questions they will ask you, what is the acid-base status? There's some question they will ask you, what do you think should be done? That's critical thinking. In the case form, if I'm the writer, I would just do that. Say, okay, what is the next step? This is the ABG. What do you think the doctor should do? Think. And the best way to know what to do is to know how to take care of the patient. You have a metabolic acidosis. Okay, you have metabolic acidosis. So metabolic acidosis, right? The best way to learn how to do that is to flip the numbers. If it's a metabolic problem, it becomes respiratory. If it's an acidosis, it's what? It will become alkalosis. So every time you see an ABG, the compensation is the treatment of that problem. So the compensation of the unless it's completely fully compensated, yeah. So the word compensation, if nobody have explained it to you, is the individual trying to correct the problem. So metabolic acidosis, you correct it with respiratory alkalosis. That is your compensation. So the nurse, the patient is intubated. The patient cannot do that. So the nurse and the doctor has to come and look at the ABG and say, we need to correct this ABG. How do we correct it? Respiratory alkalosis. Then you ask yourself, how does the ventilator do a respiratory alkalosis? Critical thinking, something you know, but some they don't explain it to you. You already know. If you come in, think about patient who has diabetes. This is classic, right? Who usually do this? Type 1 diabetes. Type 1. What are the one of the signs and symptoms when they come in? What do they do? What is one of the biggest signs and symptoms you see in type 1 diabetes? What do they do? In DKA. When you're in DKA, what do you do? What do you guys think? How did they correct themselves before even they come to the hospital? What do they do? Deep, rapid breathing, right? They're going to do Cushman breathing because Cushman breathing, they're trying to blow out the CO2 to correct the metabolic acidosis. So they end up being in the respiratory alkalosis. When they come in, they're breathing so fast, but deep, slow to get rid of the acidosis. Test taking strategy. I've given you the answer, but if you don't see, this is the answer. Look at the PaO2. It's normal. Saturation is normal. On a ventilator, FiO2 and PEEP are used for oxygenation. This patient does not need more oxygen. Therefore, test taking strategy 1 and 2 is gone. Repeating ABG is irrelevant. You don't know the answer, but you see, I answered the question without even worrying too much about other stuff. I tried to explain it to you, but I come to the easy way to tackle it. I know the PaO2 is 90, saturation is 98. They are all normal. There's nothing I can do for this patient to increase their saturation. FiO2 and PEEP are responsible for your oxygenation. Your ventilation is due to your tidal volume and your respiratory rate. And for this one, to stimulate Cushman deep, rapid breathing, you got to increase your respiratory rate so that you can blow the CO2 down. That's how you're going to compensate. So this 40 probably will go to like 30, and the pH will come up, and we have what? A normal pH, and the individual will be happy. Test taking strategy based on content. Adapt NCLEX way. How will you increase the respiratory rate? You turn it, there's a knob on the ventilator. Usually when you have a ventilator, you have to put a FiO2. That's how much oxygen in it. Probably 40% oxygen you're going to breathe. You're going to have a tidal volume. That's your lung capacity. It's not the true lung capacity, but how much air. When you take a deep breath, how much air go into your lung? Most people between 400 and 500, depending on how tall you are. Our baseline respiratory rate on the ventilator, we set it to 12. And the PEEP is like breathing in the straw. That's the pressure that is opening the airway. That is the pressure the ventilator is using to give you oxygen. It's 5. So when I see this, I'm going to increase this rate. I change it to like maybe 16. So I'm breathing for the patient 16 times per minute. And that's how you do that. So number 4 is the right answer. And the last one, and I will leave you guys alone. Go steady. Select or apply, right? Same thing. Which of the following the nurse should monitor the client for? I need to monitor you for it. A nurse is assessing a client on polystyrene sulfonate for management of electrolyte abnormality. You know what this is? That's all. If you're taking this, what would I monitor you for? Concept, right? Pharmacology. Like I said, chapter that NCLEX. If you've not subscribed and you're watching, hearing my voice, yeah, I'm adapting class. The home of content made easy, simplicity. So what do you think this is? Polyestyrene sulfonate. Do you know what it is? What is that? It's a pharmacology question. What do you guys think? What is this medication? This is K-acylate. This is what we call K-acylate. What do you use it for? What do you think we use it for? It's for somebody who has hyperkalemia. You give it through the GI tract and you get rid of your what? Your potassium. You get rid of your potassium. So polystyrene sulfonate is a K-acylate. And you get rid of your potassium. So this is the key. So what do you want to do? What do you want to do? K-acylate, you get rid of potassium. So what do you expect? The next you monitor the client with what? If I'm giving you this for hyperkalemia, I expect your potassium to go down. By the mechanism of action, it has a reason. Okay, it has a reason. It get rid of stuff, especially potassium, and he exchange it. How does he exchange? Whenever you exchanging potassium, because it's a resin system, he exchange potassium for sodium. So he decrease potassium and increase sodium. That is his main function. This is his main function. I decrease potassium and I increase sodium. Therefore, I'm going to have a hypokalemia. I should monitor the patient for hypokalemia. Now think, this is the test taking strategy. The board is going to do that. It's not going to put your potassium, sodium, therefore it's going to increase. But this is not the end of the world now. What do you think? Sodium, love water. If you love water and sodium, you add them together, you get fluid overloaded. As fluid overloaded will present in which form? You get into your lung, you get lung crackles. You get pink, fruity sputum, right? And your central venous pressure goes up. You don't have to memorize content. You got to take the concept and extrapolate. If I have too much sodium, it's like I'm in CHF. I'm going to hold on to my water. If I hold on to my water, I get fluid overloaded. What are the signs and symptoms of fluid overloaded? Lung crackles. Signs and symptoms of fluid overloaded. Pink fruity sputum. This is number 1. Pulmonary edema. You're drowning. Signs and symptoms of fluid overloaded. Central venous pressure over 20. And you don't want to say the word, hey, what are the signs and symptoms of fluid overloaded? I use this question and turn it and make it like this is basically pharmacology and fluid. If you understand the pharmacology and the fluid aspect of it, you can see the symptoms and you know that all of them, the name should monitor the client for that. This is Adapt NCLEX. Like I said, if you don't know me, I'm Adapt NCLEX, place of content simplicity. If you've not signed up for us, I mean, join our membership. It's very cheap, like you said. If you like this video, just click the like and share and then subscribe so that we can grow this channel.